Hello, my name is Joe Aldridge, and I've been a type 1 diabetic for 7 decades.
And I'm Cam. I'm a type 2 diabetic, and you are tuned in to the Diabetes Our Way podcast, where we discuss all things diabetes related.
This podcast, we're going to share a few laughs, and you're also going to learn a lot as far as what we've experienced over our trials with type 1 and type 2 diabetes.
But please note, we are not doctors, and this podcast is for general information and entertainment. It is not any form of direct medical advice. If you or someone in your life has or may have any form of diabetes, please contact a medical professional. Hey guys, welcome to Diabetes Our Way with Joe. He's Joe. I'm Cam, of course. And we haven't done one in a while. It's been a while, Uncle Joe.
Yeah, it's been about 3 weeks, three weeks or so.
We figured we'd give people a little bit of a break from us, huh?
Yeah, well, it's summertime. Everybody's getting ready to send their kids back to school and stuff like that. So it's good. But we were waiting on a great guest, and I think we got one tonight.
We were. So I will let you, since it's your guest again, I'm going to let you introduce her.
Okay. Well, I'd like to introduce Dr. Deborah McDaniel. She's a pediatrician, or she's a retired pediatrician. Now she works at the veterinarian as far as the Humane Society there. So it's kind of funny. I mean, I guess her practice went to the dogs, but I won't say that, to everybody. But we said it on the podcast. But no, she. I got to meet Deb way back in the 1980s, and just really admired her ability to look at kids in such a holistic way. And she was actually my two sons' pediatricians, and she just always did a great job. I mean, have nothing but the most respect. I still call her a country doctor, and sometimes the country doctors have common sense, and I really think that she really treated her patients like they were one of her own. And so I'll kind of let Deb kind of introduce herself and everything else, and how she got started in medicine, where she grew up, and what got her interested in medicine and stuff like that. So I'm going to kind of turn it over to you, Deb.
Hey, thanks, Joe. Well, let's see. I grew up in Greene County, Indiana, kind of in the country, and I knew pretty much almost forever that I wanted to do some kind of medicine. When I was like a preschooler, I had a little red notebook, and I would go around and make rounds on my paper dolls, and things like that. So I knew I was going to do some kind of medicine. I didn't know if it was going to be with animals or with people, ironically enough. And I wound up in pediatrics, which is pretty close to camp. There's a lot of overlap, with animals and kids. They're nonverbal. You have to use your observational skills to diagnose them. If they don't like what you do, they might bite you. There are a lot of similarities in those things. So that's kind of how I wound up where I am. And now that I've retired, I've kind of swung back to the animal side, as Joe said, with the Humane Society. So that's that.
Let me ask you. I mean, where did you get your training at? Was it at Indiana University, or exactly? Remind us as far as how you started out in undergrad and medical school and stuff like that.
Okay. I'm IU for medical school. I did my residency at Riley Children's Hospital in Indianapolis. And that's where I first got interested in treating the type 1 diabetics. I don't know if you want me to kind of segue on from there or not.
Yeah, no, I think that is a good segue, because, I mean, Jocelyn Center up there is just an excellent diabetic hospital and stuff like that. So talk a little bit about how you segued into that.
Okay. All right. I kind of feel like a dinosaur looking back all these decades, It's like back in my day.
Yeah,
But,
well, I'm right there with you.
that's
He
true. We kind of
he
came up
he does
together.
it.
That's right.
He does it all the time, Deb. So
Yeah.
So good. Okay. Well, back in the 1970s, when I was going through medical school, um, this was really ancient, I guess. You know, insulin came from pigs, right, Joe? We didn't have human
That's
insulin yet.
exactly right.
People gave injections with syringes and needles at specific times of day. And when somebody was diagnosed, we just kind of did a guesstimate of how to start them. We had kind of a 2/3, 1/3 rule, you know, where based on their weight, they would get so much long acting and intermediate acting, you know, in the morning, and evening, very certain times of day. And because of that, the diets for kids were very strict, right?
Yeah.
You know, they had to eat at certain times of day. They had to eat certain amounts of food, certain kinds of food. There was almost no flexibility to speak of. If Johnny ate dinner and he'd been running around, he was still hungry, it was like, too bad, Johnny, we'll call the dietitian tomorrow and get your meal adjusted, you know, but sucks for Johnny tonight. So everything was very rigid. Birthday parties, class parties at school, kids would bring in diabetic friendly snacks, which was usually celery sticks with peanut butter and a side of bitterness, you know.
right.
They would eat, while the other kids had the cupcakes.
Yeah, other kids had the good stuff, right?
Right, exactly. We didn't have A1C, hemoglobin A1C test, you know, to give us an average of their blood sugar over 2 to 3 months. So they would come in every 3 months or so for a check, and they would get a fasting blood sugar or random blood sugar. And, you know, Joe, I'm going to ask you, I'm going to put you in a minute. Kids aren't stupid. You know, they know how to work the system, so they just wouldn't eat for 12 hours or 16 hours or whatever. So they have a good number when they came in, you know, and we would say, oh, that looks pretty good, and you're following your diet. And they would lie to our face, you know, angelic little smile, you know, and wide eyes. We are. Yes, we are. And we wouldn't know, you know, because we didn't have a way to call it out. Joe, did you ever do that?
Yeah. Oh yeah.
Okay.
Yeah.
Yeah, I mean, I would have too.
Yeah, it's and you learn all the tricks in the trade. You know, it's just and as I said in a previous podcast, I would spend and Deb, you can maybe compound on this a little bit, but when back in the 70s, late 60s and 70s, a type 1 juvenile diabetic spent 2 to 3 weeks in the hospital at a time. They just didn't come in. You were in there, and I spent a lot of Christmas breaks over in the hospital.
It just wasn't
Any
a good...
thoughts on that, Deb? I mean, yeah.
Well, yeah, because
and so
there wasn't a good way to monitor. There wasn't a good way to know, you know, how could we change a dose when we had this one number every 3 months and, you know, usually stack of lies, which I would have too, you know.
Yeah.
Johnny's not going to say, you know, she might take away my 1 cup of happiness I get at this meal, you know. I mean,
Yeah.
So
would you say, Deb? Yeah. So would you say, Deb, that when you started to kind of lean more towards treating type 1 and type 2 diabetics in children, or was that your kind of main focus? Or
I
guess what he's asking, Deb, was like, yeah, like when you started out in your pediatrician practice, you know, did you were you the diabetic doctor? Because I think if anybody told me in town, if your kid had type 1 diabetes, to see Deb McDaniel.
Okay. Yeah. My residency was a general pediatric residency.
Okay.
I did not do a fellowship, but here's what happened. Good question. So at the last year of my residency, which would have been 1983, 84, in there, we got a new diabetologist at Riley. Okay. from California, very plain-spoken guy with no filter. So we really clicked. I just adored him, right? Because I also have no filter, as you're learning. So I wound up spending extra time on diabetes rotation and in clinic with him, and he really took me under his wing. And it just happened to coincide with some pretty revolutionary changes that were coming down the pike at that time. Human insulins, Humalog, which was huge, injector pens, so kids could dial a dose, and with the quick-acting Humalog, they were able to learn carbohydrate counting and match their quick-acting Humalog to the grams of carbs that they were eating. And they had suddenly this whole new world of a flexible diet where if they weren't hungry, they didn't have to eat as much, or if they were starving, they could eat more, and they could adjust it, just pull that pen out of their pocket, dial a dose, go in the bathroom or not, and click, and they were ready to roll. Home monitors came out at the same time. So instead of having that one blood glucose reading every 3 months, we were getting 3 or 4 readings a day. And we could adjust insulin every 3 or 4 days instead of making a guess based on the one reading and fibs we were told every 3 months.
Yeah, absolutely.
So it was a total game changer. And we had an A1C test to give us that average blood sugar over 2 to 3 months. So, you could back up liar, liar, pants on fire. They couldn't get around it, even if they made up numbers and put in their, little book or their chart or whatever they brought into the office. See, they've been perfect. The A1C would call them out. So we were able to really keep a handle on things.
Going back, Deb, you were talking about in the 1980s when that all started to transpire, and you could get the A1Cs, you could get the the glucose tests and stuff like that. So continue on with that, because I think that's a very important point.
Okay. So this was pretty radical, pretty revolutionary changing as far as we had so much more data to work with. We could adjust so much more frequently, and we weren't just guessing at things. And kids had so much more flexibility in terms of what they could eat, how much they could eat, when they could eat. They could do sleepovers. They could go to parties and have the actual cupcake instead of the celery peanut butter bitterness cocktail. They could have pizza. It gave them just this whole new landscape. And I kind of felt like the white knight hero coming in, saying you can do this, because their eyes would get so big because all their older diabetic relatives who were still on the older regimen were saying, oh, you'll never eat sugar again, and they just thought their life was over. So it was pretty revolutionary. And that's when I met you, Joe. So, and you were kind of at that same place, as I recall, right?
Yeah. I pretty much, I was fortunate to have a great doctor, and he wanted me to take less insulin, not more. And then I tended to learn very quickly what amounts of food I could eat, and they tended to be green foods, and I didn't mind the celery or peanut butter and stuff like that, but probably my biggest downfall was beer. And at that particular point in time, especially in college, I found beer and found all the other stuff when you go away to college that kind of got me in trouble, and that's when I lost my left eye and stuff like that. But then we got to the monitors and the finger pricks and everything else, and I chuckle when you said 3 to 4 times. I was doing it like 18 times a day, and just just because I was really kind of conscious about that. And then the big thing I noticed too, the difference between the pork insulin and the human insulin is that the human insulin, 100% of it got absorbed, whereas the pork insulin, only about 70% got absorbed. So, it would, I would have to. I had a lot of reactions, and I was very lucky not to have to ever go to the emergency room, for a low blood sugar at that particular point in time. But I played sports. I did everything. I was fortunate. My dad and my mom. My mom wouldn't let me play football, but I could play any other sport there was. And my dad always said, "You are not going to allow this disease. You can't use this as a crutch. You can't use this as an excuse." And so, and they stood up for me when, other parents wouldn't allow their kids to play with me, and sometimes back in those days, if you were type 1 diabetic, you were discriminated against. The coaches didn't want to coach you. They were scared that, the liability and everything else. And it just, my parents wouldn't put up with it. And they just said, you can't let this limit you. You can do whatever you want to do. And so I feel very fortunate that, that I had two great doctors, Stanley Bryan back when I was growing up. And then I had Lee McKinley when I moved here to Bloomington. And then it was also great to meet Deb McDaniel because a little known fact is Deb used to have me come in to the old Bloomington Hospital, and when I was able to, or the hospital rules allowed you to, I was able to talk to several type 1 diabetics about, hey, you can survive this.
Mm-hmm. So. Yeah. And, that's an interesting point, you're talking about not using it as a crutch. Doctor, when you were treating, children with type 1 diabetes, did you notice, like, their mental, I guess, did you find that more of them became more depressed versus, or kind of getting, having a less of a mental state, because they had the disease? Like, did it affect their mental health?
I think the younger kids, and Joe, you can weigh in on this, actually did pretty well, as long as the parents, were parents like Joe's, right? And they were pretty matter of fact about it. They really were. It's like, okay, this is what I need to do now. Can I go play? Mm-hmm. I think where I saw the difference was puberty. I hate to even say the word, because that's kind of a minefield, even in a teenager who doesn't have diabetes.
Mm-hmm.
Yeah.
You factor in one that does, though, and what better way to rebel than to stop doing all the things you have been doing, or that your parents are invested in, and you get mad at mom or dad, and just don't check some sugars and go in the hospital. That's a great way to get back,
Mm-hmm.
So if there was any little bit of family dysfunction, or even just a rebellious teenager, then they would go off the rails a lot of times when they hit their teens. And I saw that a fair amount.
Oh, I would totally agree with that. I think puberty was very tough because your body's changing, everything's changing, and then, and Deb, you might dig a little deeper on that, but, especially too, as, I don't want to get, I don't want to get rude or anything like that, but when all of a sudden a young girl all of a sudden, gets her period, and then the boy can do, what he can do, it's got to have some really hormonal, am I saying that right? Hormonal changes, and that has a drastic effect on the diabetes control, doesn't it?
It does. It does. I feel like girls probably had a rockier time, because they had those monthly fluctuations, and you could see it. You could see it. They could tell when their period was going to start because their sugars would get out of whack, for a couple of days beforehand. And I think, because of that, they had a harder time. And quite honestly, I think they had a harder time just because teenage girls can be pretty brutal, when it comes to body image and bullying and that kind of thing. I feel like guys are a little more, if you don't like a guy, you kind of punch it out and then go off and
Mm-hmm.
play sport, play together. And girls are a little more, I don't know, they're just a little more brutal, I think.
Yeah.
So there was a lot of that. But I think we saw diabetic burnout in teenagers quite a bit, because it's always there. From the time they're diagnosed, everybody is focused on food. What are you eating? Constant monitoring, ups and downs, the roller coaster of the blood sugars and all that. And they just kind of get over it. Even kids who are on pumps, will have parents texting them at school, bolus, you need to bolus now, And I think when you hit that time in your teens, when you got your body image issues and and you have reasons to rebel. I mean, that just it's just 500% worse.
Mm-hmm. Absolutely.
But that's probably even in. So really, it's kind of a two-tier there, though. You go from high school, where it is really clicky and all those kinds of things, and you said it can be bullying and stuff like that. Then all of a sudden you go off to college. Then it's like a free-for-all. I mean, college just started here, especially here, and I always chuckle because, having people in the family that work at the hospital and stuff like that, it's like, well, the emergency room visits, not just for diabetics, but for normal people, goes way up, that first week or two. And just because it's almost like I'm totally free, I'm going to do whatever I want.
Exactly. Yeah, and as you said, beer and pizza are the two biggies.
Yeah.
And those aren't good for too much of that's not good for diabetics.
Yeah, well, anybody, but yeah, especially.
So that kind of leads me to one of the topics you want to talk about was athletics or athletes with diabetes. So what'd you see when you were taking care of those? And did you mostly take care of grade school, then high school, and then did you take care of some college athletes?
I would say it was mostly grade and high school. I had few college athletes. And again, it kind of depended on where in the history or the evolution of diabetes, they came up. I mean, it's a dance that athletes have to do. If you're doing super high intensity interval things, yes, your blood sugar can go up. But I think most athletes worry more that it's going to go down, if they do too much. So they'll show up for their event with Gatorade along with their water, with Skittles or dried fruit or something to bring their sugar up if they start to feel really low. We try and have them, do some protein before their event. But again, they don't want to eat too much protein because if they're too full, then they feel like they aren't going to perform as well. So it's really kind of a dance that they do. And I think with the pens, it wasn't, they did okay with the pens. When the pumps first came out, like in the early 2000s, when the tube pumps came out, a lot of the athletes weren't that excited about the pumps because the early pumps weren't waterproof. They had this tubing that they would have to wad up and tape down, and come up with ideas for how to do that. And a lot of them didn't want something attached to them during their event, So I feel like that's not as big an issue now because we've got these great tubeless pumps, which have pretty much revolutionized. And I'm assuming, are you on a tubeless pump now, Joe?
No, but I'm looking to go on the Omnipod.
The Omnipod, yeah.
So,
I was going to
the
say.
Omnipod with the Freestyle Libre 2.
Okay.
So that just came out. So
Okay.
yeah, exactly what you said, Deb. I did not want something hanging off my side. And like you said, with all the tubes, and then of course back then, early on, a lot of those pumps malfunctioned and almost sometimes gave too much insulin. There's a lot of diabetics had to go to the emergency room from
Right.
my doing the research.
Right. Or the tubing plugged up and they didn't get enough, or it could go either
Yeah,
way.
they
Yeah.
go
So
too
early
high.
on,
Yeah,
yeah, they weren't great, and early on they didn't have the CGMs, the continuous monitoring systems either.
Right.
So they were still having to do finger sticks, still having to check on their meter. And they're like, well, if I'm doing that, I'm just going to use my pen. It's just
Yeah.
easier.
Yeah.
So I did see that. Now the pumps now, though, the Omnipods and especially those closed loop systems, I mean, they're pretty impressive. And a lot of athletes are just using those and staying with those, and they're doing really well.
Yeah.
I talked to one of my old partners earlier this week, and he said pretty much practically every type 1 diabetic now in the practice is on a closed loop system.
Yeah.
Yeah.
Yeah. I go in next week for my education and stuff like that. So, but yeah, Cameron, you want to comment on that?
Yeah, well, I was just I was curious because I'm a type 2 diabetic, so I'm not type 1, and I'm monitoring, of course, with my monitor as well as eating right, and I've always noticed that when I go to the gym or I work out, right, I'll dip low right after my workout or late into the evening, and I've done some research that's because your body will use all the stored glucose that's in your body up first. So I guess how fast does it go? How fast can you restore those levels back up? So you don't really have to worry so much about going super low or worrying about not overextending yourself or eating the right thing, because I notice that that's always the first thing when I'm working out and I get home from the gym after I shower and everything late in the evening. Like I'll pop into like the 58s, I'll start dipping low, and then I've got to eat something, to get my sugar levels up, because I knew that I already worked out all my storage levels. So when do those get put back in your body, and how fast?
Man, I think that's probably kind of an individual thing. It depends, what you were doing, how intensely you were doing it, and just I think it's going to vary person to person. I will say a lot of non-diabetics even are using the CGMs, the continuous glucose monitors now. Like if you're at Disney or at a concert, you look around, there may be 30 people with a little, thing on their arm, and they're not all diabetics. One of my old partners is training for a marathon, and he got one just because he wanted to know. And he said, if I go out and run 8 hours, he said, I can just blow through the carbohydrates and just, he said it takes forever for me to get, up into a range where, I'm comfortable or I stay comfortable. So, but there's maybe a place for them even for non-diabetics.
Yeah, that's interesting. That you said that, and I think about that now. It's like, yeah, if I'm like running a marathon or I'm training for an Ironman, you would want to know what your blood sugar levels are in case you crash out.
You'd like to think you could keep it up, but he said there's definitely a big difference if he runs 8 hours. In what happens.
But do you find that if more people start doing that it's going to be harder for diabetics to get the items that they need? Because we're seeing it now with the shots, like your Trulicity, your Mounjaro, your Wegovy, and Ozempic.
Because people just want to be skinny.
Yeah, and we talked about that before.
That's the same answer McKinley gave. Yeah, they don't want to do it the hard way.
Exactly. I mean, you can get over-the-counter ones, without a prescription that are different brands, and I think that's what,
Oh, okay, gotcha. Yeah, because that's the one thing I don't want to. I want to be able to get my stuff. I don't want to have to wait.
Right.
I wanted to give you a stat. So, guess how many division or NCAA athletes there are in the United States for all schools? Division 1, 2, 3, junior college.
Oh my goodness. No idea. Millions.
Cameron, you want to guess?
I say you're probably looking anywhere 2 million.
200,000.
200,000. Okay.
Yeah. Can you hear my dog in the background?
I can. Yes.
Yeah. Hey,
Hi, Arlo.
Lisa. So,
Well, this
so
podcast
anyhow,
is
sorry
going
about
off the
that.
rails.
It is.
You'll talk.
So anyhow, out of that, so there's 200,000 student athletes playing college sports. So from that, they use an average of between 0.15 and 0.52 or 0.57. So I just took that average, which is 0.42. So that means that there's about 8,400 kids playing college sports with type 1 diabetes. That's just type 1 diabetes, not looking at the football players and everything else that might be type 2 diabetics. But yeah, I thought that's pretty interesting. And I can remember way back when the pump and that first came out, basically seeing a guy have an insulin pump, and they were talking about that, and he would come off the football sideline, and he was over there doing the pricks like Deb said, checking his blood sugar, and basically making sure that his sugars were staying within range because he was playing as an offensive lineman. So it's pretty amazing.
Mm-hmm.
So
the pumps are getting smaller and smaller too.
Yeah.
Yeah.
Well, even now, like you see more partnerships too with I know Dexcom is doing a partnership too with the NCAA. Celebrating athletes who have type 1 diabetes. So I think it's great, and I think with the amount of medicine and research and data that we have today, I think we should be able to have better stats on that. But I think the programs that these athletes go through, especially if they're type 1 or type 2, I think has just gotten better over the years. I mean, you even said, during your course and your residency, you started to see the great changes that, diabetes has made in ways of technology. About how many children on average, when you started, would you say had a type 1 diabetes?
Oh, I'd say the vast majority of what we see in our practice was type 1.
Mm-hmm.
Vast majority. There was a peak probably preschool age and another peak 11, 12, kind of early puberty.
Mm-hmm.
But the vast majority were type 1s. The second group that we saw were pre-diabetics. We saw a fair number of those. We usually would pick those up on just routine checkups. Because they would come in, their BMIs would be over 30, which would trigger us to check what we called Zoftig labs, which Zoftig, if you look up the definition, it's a Yiddish word that means plump or round or, so I said it's that fine line between being voluptuous and matronly that I constantly straddle. That is, So we would draw those labs, which would be like a lipid panel, an A1C, and liver function test. And we picked up a fair number of kids with fatty liver or pre-diabetes, just on that screening, which was probably the second biggest group, that we had.
Yeah.
So I think probably nowadays, if you were still in practice, you would probably see more type 2 diabetics. Because McKinley was talking about that.
Yeah.
We're seeing definitely more type 2s.
I was going to say more pre-diabetics.
Right. It takes a while to become a type 2, so we picked up a lot early on. But we still are seeing some type 2s, and as I know you've talked about on your other podcast, it's not all black and white anymore, Someone can kind of look, you think they're a type 2, but then they're spilling ketones, so maybe they really, aren't making enough insulin and don't respond as well, at the cellular level. So you can kind of have a mixed bag. So our type 1s usually would be pretty dramatic. I mean, they would come in with big weight loss or, in the ICU with the blood sugar. Okay, Arlo. Um,
And we actually got our Arlo from Deb.
yeah.
Oh, okay. So
Yeah,
she
so
hear,
Arlo came from Deb.
so recognizes your
Maybe
Probably
voice.
heard
Deb,
my
maybe Arlo remembers her.
Right. I will say, while I'm talking about the type 1s that we would see, um, just a couple of, I don't know if they're fun facts, but a couple of little ditties here. You know, we think of type 1s as more autoimmune as a rule, right?
Mm-hmm.
Um, and a lot of times in the past, it would be triggered by some kind of virus. Influenza B was a biggie, I feel like triggered a lot of kids when I was in practice. Um, but there was a pretty big surge in type 1 diabetics during COVID. And we think, maybe that was a trigger too, which I thought
Wow, I
was
didn't
kind of
know that.
interesting. Yeah, yeah. And so that goes back to that thing. And the other thing that just cracks me up, there's something called the hygiene hypothesis. Have you heard of that?
No.
Okay, dirt is your
Possibly.
friend. Yes, dirt is your friend. If you have the kids that, and any pediatrician will tell you this, the kids who are out rolling around in the mud with no shoes on and eating rocks never get sick, right? I mean, and throughout their life, they tend to be pretty healthy. But if you have too clean of a childhood and later on you get exposed to a virus, you can have this overreactive immune response. It's like your immune system is, I'm here, coach, put me in. I've been on the bench, all my life. I
Mm-hmm.
want to do, you know, and you get this big overreactive immune response. So there's a theory that if you're too clean as a child, you're a little more prone to autoimmune kind of things, which I thought was kind of interesting.
Yeah,
Yeah.
I mean, that is pretty interesting. I mean, it's similar. I think that same mindset happened during the whole COVID thing. Was that, well, don't you want to be exposed to certain elements to help your immune system adjust accordingly? Uh, so I can definitely understand what you're saying from that standpoint. When it
Yeah,
comes
well,
to,
COVID was a
yeah,
different critter. I,
yeah,
I wouldn't go roll around in COVID, but yeah.
yeah. Well, when it comes to taking like medicines, like if you're sick, that's one thing that was I was always fascinated with is the types of medicines, like if you have the flu or if you have a cold, that you would take that have more of a positive or negative response to your sugar levels, or are there ones that you should really stay away from?
All right. Um, I think with kids, the big thing we had to watch was liquid medicines and syrups. And we would, have lists for parents, if you really want to give something, for this runny nose, don't use these because they're full of sugar, but this
Hmm.
one's okay. This one doesn't have dye, doesn't have sugar.
Okay.
And with some antibiotics, but it was more that kind of thing with some of the syrups and the liquids that we saw.
Right. So
Yeah.
stay away from syrups in your medicine. Kids might not like the taste of it. Even, they don't like taking medicine regardless, but if it doesn't taste good, they're really not.
Well, actually, if it doesn't taste good, it's probably better for you.
Yeah,
Yeah.
unfortunately, that's how it works.
Hmm.
Same
Hmm.
thing with
I
food.
grew. I grew up though. When I grew up, my mom was like Granny on the Hillbillies. She just gave me a shot of whiskey.
So did mine. She thought it worked great. She thought it worked great as a cough suppressant, but we would be in there with a pillow over our heads still coughing because we were afraid she'd come back and give us another
Yeah, I
dose.
know. There's what they used to call the old hot toddy.
Yeah, yep,
The old hot toddy.
that was it. That was it.
So
Yeah.
it definitely clean up your sinuses.
Exactly. Exactly.
So,
And now
I,
you've transitioned into helping pets, and I'm curious, pets with diabetes. That's always
yeah,
another interesting
that's a
topic
great
as well.
segue. I'm glad you brought that up, Cameron.
oh,
Yeah. So are you seeing that a lot in pets?
oh, I don't know. if they're seeing it a lot, because I mainly am on the surgical end. I will say one of my old partners does have a diabetic dog, and his wife, God love her, checks not fingers, paw sticks, I guess, ear sticks, on this dog, and adjusts the insulin, and this dog has been living a long time with diabetes.
Wow.
So how do you get blood out of a dog?
Yeah, I know. You need to have her on here. Do a whole segment on just diabetes.
I mean, I'm just interested how dogs actually can get diabetes. It's so fascinating to me.
Yeah. I mean, the same basic, pancreatic dysfunction. But yeah, I'm not sure. Like I said, because I mainly did surgery.
Okay.
As opposed to the internal. And I'm not saying it's common at all, but they do see it. And they do see it in cats. My son has a diabetic cat. So.
I thought it was interesting because with going back to McKinley's talk about, a lot of diabetics would go in with fatty livers and stuff like that. And I always found that interesting because, early on they would say that, and they, of course, they naturally think, you're a boozer and stuff like that. But there's just must be something with the diabetes that, has an effect on that liver.
Yeah, or which came first, the chicken or the egg, because kids with fatty livers are at increased risk to go on to type 2 diabetes. So it's kind of, what about their metabolic syndrome ties all that together, for sure.
And then,
go ahead, Cameron.
Well, I was going to say, at what age do you recommend a child start kind of taking over the duties of managing their own type 1 diabetes?
That's a good question. It really depends. I feel like a lot of kids, somewhere around middle school age will at least start, transitioning, like doing their own finger sticks, working the meter on their own. I think if they're on a pump, that's a whole other critter, because then I think the parent's going to run things a lot longer but the pumps even, as Joe will find out soon, the way those closed loop systems are, I mean, they literally will put in their blood sugar and what they're eating, and they can put in the number of carbs, or just put in, for some programs, they can even just put in the food, and the program knows, how many carbs. And then that calculates the bolus, and all they have to do, it looks like they're texting. All they have to do is just put in the bolus amount. And kids are so techy now that, they probably would do better with it. My grandkids would do better with it than I would. As far as that, but I think it depends. It depends on the kid. I had kids who started, were pretty well on their own by high school. I had kids who were about to leave for college and were still struggling. So a lot of it depends on how independent the kid is, how bright the kid is, fine motor skills. I mean, there's so many pieces. But I do think that these closed loop systems help a lot because the system automatically does all the basal levels. So the only thing they have to think about is bolus when they eat.
Yeah, absolutely.
So.
Well, we've asked this question before. We asked this to Dr. McKinley, and we'll ask it to you. How confident are you to think that we'll probably have a cure for diabetes one day?
Oh, how motivated are they to look for it, right? Good question. I mean, I know they're still looking at beta cell transplants, islet cell transplants, and they've done those. The piece of that puzzle is nobody is excited about going on immunosuppressive therapy, right, to prevent rejection. I know there were papers presented within the last year where there's some studies going where they're doing genetic engineering to try to mask the islet cells, so once they're transplanted, the body can't see them, the immune system can't see them, and then those people might not need to go on anti-rejection meds, and I think that's what they're looking at now, which would be great, because that's the big piece. I think they can make the cells in the lab. They've got the stem cells. They can got that piece solved. So they don't have to wait for donors or anything now, which is huge. But the next piece is the anti-rejection meds, and if they can get that piece figured out, then maybe you're looking at something. And some people with the beta cell transplants, I want to say 70% maybe, could go totally off insulin or markedly down, but a lot of them totally off for anywhere from 1 to 5 or more years. So I would hope maybe someday.
Yeah, absolutely.
That would be,
And what advice would you? I was gonna say, what advice? I'm sorry, I didn't mean to cut you off there, doctor. When you're talking. But what advice would you give parents who have children with type 1 diabetes who are struggling, with trying to help manage it and also raise their child with type 1 diabetes? What advice would you give them?
I mean, just this is your child, and yes, they have diabetes, and yes, we have to manage it, but to take a page from Joe's parents, and let them be a kid and try to manage it without it becoming the absolute center of the universe, I guess. And I think, again, I feel like I'm doing advertisements for this closed loop system, but almost all of our kids are on it now. And the nice thing is they don't have to constantly think about it, when it's time to eat, do your little app. Kids understand apps, so it's not as big a deal. And I think because the pumps are so much smaller now, that kind of helps destigmatize it, I guess, for lack of a better word. I have to tell you this movie, number 1 on Netflix right now, streaming, is K-pop Demon Hunters. I don't know if you've seen this movie, but my grandson told me this. K-pop Demon Hunters is the name of it. One of the characters in this movie starts it, and it's apparently got a lot of mental health undertones. I mean, it's not just a cartoon for kids kind of thing. But one of the main characters at the start of the show has what appears to be an Omnipod or something along those lines on her arm, but it's covered up and disguised, right, with material and things. And as the show goes on and her self-esteem improves and she realizes it's okay to let people, see you're a little vulnerable or whatever, at the end of the show, it's uncovered. They never say a word about it. They never address it verbally throughout the entire thing, but it's just there. And one of my grandsons noticed that and told me.
Yeah.
So I thought that was way cool.
And what's the name of the movie again?
It's called K-pop Demon Hunters. And it's like an animated kind of thing, but apparently it's really good. It's been number 1 for quite a while, which I haven't watched.
Okay.
I've not watched it. He said, I'll watch it the 4th time this week with you if you tell me when you can watch it. So it must be pretty good. But.
Well, we were talking on the last podcast about how now Barbie has an insulin pump. Barbie's releasing a type 1 diabetic doll that has an insulin pump. So it's real interesting.
Uh-huh. It is.
But that ad's backed by Ozempic.
No. They wouldn't like that.
Well, it's interesting, Deb. I used to go to the bathroom to give myself shots. So I'll test my insulin when we're out eating, or test my blood sugar when out eating and stuff like that. And I'll go, okay, I'm taking, 27 carbs, so I need to take 3 units. I just pull my insulin out of my pocket, pull out 3 units, pull up my arm. I just give the shot right there, and And if anybody comes up to me and they want, oh, they're offended or whatever, I said, well, you know what? Find a cure for diabetes. I won't have to do this.
Mm-hmm.
So, you get a little bolder when you've had it as long as I have. But, my advice is to tell those parents, don't use it as an excuse. I mean, I tell the story, and Deb, I don't know if you heard the story, but I'll never forget, I was feeling sorry for myself in the hospital because I couldn't go home for Christmas. And my dad took me down the hall, walked me down the hall after listening to me bitch and moan and groan and everything else. And he said, are you finished? Walked me down the hall and showed me a kid wrapped up who had brain cancer. And he said, that kid, look, he's here by himself. And I don't know if he's going to come out of this alive. He said, Joe, it could always be worse.
Absolutely.
So, I think if I was not diabetic, I wouldn't be the person I am today.
Mm-hmm. Mm-hmm. Absolutely. That does remind me one thing that you kind of touched on earlier, and that's who are really effective counselors. And you had talked about, going in early on when we first met and talking to some newly diagnosed diabetics for me. And I do think that, especially early on, the diabetic educators, the certified diabetic educators, do a great job. And they're
Right.
good to teach survival skills and all that. So it's nothing, at all to trash them. But I think early on, especially when people are just reeling from that diagnosis and they're so stressed, they don't hear a lot and they need to decompress. And I think it helps so much for somebody like you, or I had one other parent, a mom who had 2 diabetic kids, who would go in, and I will never forget this. She would take a sack of cucumbers into the room with her, and she would sit and slice these cucumbers while she was talking, and she'd say, now these are free foods. We'll just munch on these while we're talking. And she would just sit and talk about her kids and just the day-to-day, in the trenches things that these parents who were totally deer in the headlight, hadn't even thought about yet. And
Yeah.
they would think of questions, for her or for somebody like you that they wouldn't have thought of, with an educator who was going through the modules, the survival skills, all that kind of thing, especially early on. And you could just watch them start to relax and decompress. And then when the parents did that, then the child would do it too, over time. Oh,
Yeah.
it's going to be okay, So I do
Well,
think
I
that
chuckle
really,
because you're absolutely right. And don't get me wrong, there are great diabetic educators and everything else, but I'll never forget this happened when there's a transition and I had to leave McKinley and basically have to go out and find a new diabetic doctor. And I went to a couple new ones that came right out of this, and I just chuckled because I wasn't hitting it off very well with this particular doctor. And it's like anything, if you don't like the person, go ahead and fire them and move on, regardless of what type of work they do. And but I'll never forget, she was really pushing to get onto a pump, this and that and the other. This is back before, like you said, it was still the tubular pump. And I was bringing up all these things about that. And she said, well, she said, she goes, I guarantee you, she said, if I was diabetic, I would be on a pump. And I said, well, doctor, you're right. You said one key word in that. It says, if you are diabetic. I said, I've had diabetes longer than what you've been alive. And I said, so I think I'm going to continue to do it my way. And I wish her the best. And she didn't last in Bloomington very long.
Yeah, that's true though. See, when you go and talk to patients, you've got street cred, because you've been there. And
Yeah.
people
Well, maybe I need to start that when I retire. What do you think? Maybe that
I
could
think
be my
you'd be
new.
good at that.
Yeah. Maybe I can bring you and Arlo in.
And Arlo, Arlo is a therapy dog.
Yeah, I don't know what kind of therapy though.
Talk therapy for him.
Well, I think we probably ought to cut it short. I think we've kept Deb long enough. What do you think?
Yeah, we just want to thank you for your time, Doctor, for coming on and chatting with us a little bit and giving us a little bit more education, especially from the pediatric side of things. But if anybody has any questions that for Dr. McDaniel that we talked about today, feel free to email the podcast at diabetesrway@gmail.com, and we will answer them. So, but thanks again.
I was going to say, and Deb, we'd like to have you back on in the future, since this is kind of what we do.
Yep, this is great. You're doing a great job.
Oh, thank you. Appreciate it. So,
all right.
Well, like and subscribe, everybody, and have a great day. Thank you, Dr. McDaniel, and stay tuned for our next podcast coming out.
Okay. All right. Good night, everybody.
All right.
Bye.